We are delighted to have Dr. Nasfat Shehadeh with us today. He has been a practicing oncologist in Charlotte for over 6 years, working with solid tumors, blood cancers, and with an emphasis on breast cancer. He is currently with Oncology
So
Specialist of
breast cancer
Charlotte
topic is
and
very
was
vast
previously an
topic.
oncologist with
Tonight I'm
Novant
gonna
Health.
spend a little bit more time on chemotherapy because it's still a very important issue for patients. When any patients with cancer, when you talk about cancer, to them chemotherapy, the first thing comes in mind. Oh my gosh, I'm going to get chemotherapy, the side effects, and I'm sure they have seen loved ones, friends that went through that experience. So about breast cancer tonight, just as a bit of introduction about statistics and staging, something like basic information that I like you to be aware, and also what kind of tools that help us to decide who's going to benefit from chemotherapy and who does not need chemotherapy. We're going to talk about also briefly about chemotherapy classes. Chemotherapy is a general term, but there are many, many types of chemotherapy. They have different mechanism of action and different side effects depending on the mechanism of action. I like to spend some time on side effects because this is very important. Our patients go through that on a daily basis, and we always educate them. And best educated patient is the best patient, because once you educate the patient at the beginning, they have better way of handling the side effects. And also we'll talk about some side effects. There are so many side effects of chemotherapy. And tonight, maybe I'm going to be talking about the chemotherapy. I'm not going to talk about the new fancy targeted agents. There are so many new drugs for breast cancer and other cancers, but feel free if you have a question to ask me about any drug that comes to your mind. I'll be focusing on nausea, vomiting, diarrhea, fever, and neutropenia, as well as hair loss, which is very important and dear to patients. So statistically, breast cancer is still, unfortunately, a very common cancer. Almost 200,000 cases every year diagnosed with breast cancer. And still, unfortunately, we're losing good number of ladies before breast cancer. If you look at the curve there, it depicts what we call the mortality rate of breast cancer over the last probably 30 years. And thanks God, we have made some progress over the last 30 years that you see the curve is going down, which means, that mortality is going down. So if you go back to even to the early 70s, look at that, 34 patients die per 100,000, and now it's down to 20. So there's almost, I would say, more than 50% decline in mortality, which is great news, but still long way to go. Very important when we talk about breast cancer or any kind of cancer to talk about the stage. Stage will determine the prognosis as well as the way we're going to treat patients. In general, most of cancers, and breast cancer particularly, comes in 4 stages, 1, 2, 3, 4. There is a stage called stage 0 or a precancerous. This is a very common, actually. We see it in patients called carcinoma in situ. Basically, the cancer is still confined to the ducts, but did not go through the basement membrane. But once it goes outside the basement membrane, that kind of confined the ducts and goes maybe up to 2 centimeters, but did not go to the lymph nodes, called stage 1. Then if it goes above 2 to 5 centimeters or involves, small lymph nodes, called stage 2. Once it goes stage 3, it means the size is bigger than 5 centimeters, or there are multiple lymph nodes in the axilla that are involved. Unfortunately, we still see some patients stage 4. Probably still, it is probably 10% of patients that present with stage 4, still high, but it means that the cancer is spread outside the lymph nodes, either to the bones, which is a very common destination for breast cancer, liver, and lungs. We don't like to see stage 4 cancer. So what are the treatments that used in breast cancer? There are multiple modalities of treatment. Some patient needs 1 or 2. Some of patients need more than 3 or 4. So surgery, chemotherapy, radiation, hormone, immunotherapy, and targeted therapy. Briefly, I'm sure survivors with us went through surgery, usually either lumpectomy or mastectomy. And I don't want to go through that in details, but we prefer to do lumpectomy. We like to do what we call breast conservation. This is like becoming like a benchmark of any breast cancer program, how much you can preserve the breast. And still, unfortunately, across the country, probably 50% still people going to mastectomy for whatever reasons. Obviously, there are certain medical indications that you have to do mastectomy if the tumor is big, if it's like multifocal, etc. Chemotherapy is important, and we're using actually less chemotherapy than before. And the way we do chemotherapy, there, I'm sure you guys hear about these terms: adjuvant, neoadjuvant, or metastatic disease. Adjuvant means usually this is a treatment that is given after the patient undergoes surgery for curative intent. So usually we do it after. It's kind of an insurance policy to give it to the patient, but it's hard to know if it works or not, because what determines the outcome of that is, God forbid, if the cancer comes back or not. Versus neoadjuvant, which we are doing way more now, specifically in certain patients, particularly like triple negative or HER2 positive. We do it before surgery. It has a lot of advantages. You can see that the tumor is shrinking, responding to chemotherapy. Usually patient still having like what we call intact, anatomy, that the cancer cells respond well to chemotherapy. And also, if it doesn't work, you have the option of changing to something different. For metastatic disease, unfortunately, these patients, they are not cured, though recently there are some maybe small category of patient, maybe HER2 positive, maybe triple negative, can be cured with certain aggressive chemotherapy. So this is like what we call the timing of chemotherapy: adjuvant, neoadjuvant, or metastatic disease. Radiation is another topic, a huge topic. Usually, if somebody goes to lumpectomy, we do radiation therapy with certain exceptions. Most of the patients who go into mastectomy, they don't require radiation, except if the tumor is big or the patient has multiple lymph nodes. And the technology of radiation therapy improved significantly over the last 10 years because of like what we call IMRT, and that's called also another huge topic. Hormone therapy, we use it frequently, particularly patients with estrogen positive. This is not the topic of my discussion tonight, but I'm sure survivors, good number of them, have received hormone therapy, and maybe another time, I think it maybe warrants to talk about it in more details. Lately, you cannot escape talk about cancer without kind of alluding to the immunotherapy. Immunotherapy is like the hot topic in the last 15 years in a lot of cancers, and actually it makes it possible, even stage 4, certain cancers right now, stage 4, which we treated in the past for what we call palliative reasons, we can cure some patients now with immunotherapy, mainly like melanomas, some patients with the breast cancer, with the lung cancer. Immunotherapy, unfortunately, in breast cancer is still kind of in the early phases, but there's a lot of work to be done. And there are like a couple of drugs approved. We'll talk about that briefly. And then targeted therapy. This is like the kind of basically looking at certain procedure, a certain mechanism of cancer that particular target them with certain drugs that works most of the time, like on the cell surface, whether HER2 or VEGF, etc. And again, I'm not going to talk much about targeted therapy. So how do we assess the risk in somebody who had early stage cancer, which means like stage 1 or 2? Because in the past, we used to give a lot of chemotherapy to these patients. Now we have better tools. We're going to talk about it. So classically, the stage is determined by the size of the tumor, 1 to 2, 2 to 5, and above 5, for example. This is the staging system. How many lymph nodes and where are they located? The age of the patient. So somebody who's young and healthy, different than somebody who's 70, 75, and they have multiple comorbidities. We take that into consideration, whether we're going to give chemotherapy or not. Tumor grade, how does the tumor look under the microscope? And these are the 3 things that every woman with a breast cancer should know. And we tell them, it's the standard of care to know what we call the hormonal status: estrogen, progesterone, which are related, and very important, HER2. HER2 is a receptor that is overexpressed in about 20% of breast cancer, and used to be one of the most aggressive breast cancer. Now, because we have great drugs for this receptor, it actually is good to have it. Then there's some computer programs that when I was in training, I remember 15 years ago, we used to plug this information and would come with a number. What is the risk of cancer coming back, and what is the benefit of chemotherapy? Now things changing. We have new tools in the toolbox, and now we have genomic data where we can dig deeper to the genomics or the structure of the DNA of the cancer cells, and we can get certain what we call gene signature, including Oncotype DX. We're going to talk about that really in some details because it's kind of exciting about it, and also MemPrint. So in the old way, how we used to decide, let's say a patient had breast cancer, whether stage 1, 2, let's say give her a risk of recurrence about 15%. So this patient, usually will offer chemotherapy. I mean, we did this for 15, 20, 30 years, that if your risk of cancer recurrence above 10%, you get chemotherapy. But if you look at these, let's say we take 100 patients who have that risk, and you look at them retrospectively, actually 85 of the 100 patients is going to be actually disease-free, whether we give them chemotherapy or not. We are giving 15 patients chemotherapy, but guess what? We are only benefiting 4 patients. 11 of those patients 11 patients of that 15, even with chemotherapy, cancer came back. So out of 100, we gave a lot of chemotherapy just to benefit 4. So it's kind of an old way of doing things, but when you have a breast cancer or any kind of cancer, you're going to take everything possible to decrease the risk of cancer coming back, because if the cancer comes back, God forbid, it becomes incurable. So in new ways of reduction, what we call gene profiling, we talked about that, the Oncotype DX and the MammoBrent and BAM50, and there are probably 3 to 4 gene profiling platforms that can help us to decide if the patient benefited from chemotherapy. Even there are some platforms that tells us whether the patient benefited from hormone therapy and how long, 5 or 10 years. There is a concept called, or a new way of looking at things called proteomics. Gene profiling is looking for the DNA, which is like the double helix structure in the nucleus of the cells. But DNA its job is to produce proteins. And so we can actually analyze certain proteins better in the blood and with the new technology. Now, things in the last 7 years, we do something called gene sequencing. The gene is like a structure in the DNA that has thousands and thousands of nucleotides. We can sequence that. The human genome was sequenced 10, 15 years ago. It cost more than $1 billion, and it took more than a year. Now we can sequence all that genome in less than a day for probably $500. So the cost of doing gene sequencing went down significantly. So the test that we have been doing for a long time is called Oncotype DX. What they do for that test, basically the tumor that was resected from the patient, we send it to a company in San Francisco. It's called Oncotype Genomics, and they analyze the DNA, and they come with what we call a report that I'm going to share with you. And you share with the patient, and you go through the data. And this is what they do. I mean, we have so many genes that can help us predict whether the cancer is aggressive. Some genes, what we call predict favorable prognosis, what we call favorable genes, and some of them are unfavorable. And what they do, actually, they looked at these genes and they come with a score. And the score is from 0 to 100. And if the score is below 18, we call it low risk. If it's above 31, high risk. In between, intermediate risk. And according to that, we can make some decisions, and as I'm going to show you down the road here. So, and this is the report that you get from the company, and you look at the patient, and that tells you in that report what is the chance that the cancer is going to come back in the coming 10 years. And here we're concerned and interested in the cancer that is coming back, what we call distantly, outside the primary tumor, because sometimes patient has a breast cancer and it comes back in the same breast, and that can be easily treated. Sometimes if she has lumpectomy before, we can do mastectomy and get maybe chemotherapy, and we're done. But somebody who has distant metastatic disease, that they cannot be cured. So this Oncotype DX is looking at the chance or the risk of the cancer coming back outside the breast and the lymph nodes. And this is on the x-axis, what we call the score, and in the y-axis here, the chance for the cancer coming back. And this is the green, low risk, the orange is intermediate risk, and the red is high risk. And if it's above 31, as you see here, the mark here, it means that the cancer risk is coming, it's pretty high. And these patients, usually we will offer chemotherapy. Low risk, in general, we do not offer chemotherapy. And the intermediate risk, this is like a controversial topic for the last 10, 15 years. There are other factors that can help us to decide. But when it's high risk, it's pretty clear that you need chemotherapy. And this is another curve here. It showed that on the left side here, if you have low score and you look whether you receive chemotherapy, those what we call the survival curves or disease relapse-free survival curves, they are on top of each other. Basically, chemotherapy has no benefit. If you look at the curve on the right side, you see how much the wide gap between the two curves. The top curve is patient who received chemotherapy. Basically, their risk of recurrence is pretty flat. It's not that high. But if you look at the yellow curve, once the curve goes down, we don't like that in medicine and oncology. Though it goes down, it means the cancer is coming back and the risk of death goes up. So I'm going to give you an example here. This is a young lady who has a tumor, 1.5 centimeter. She's healthy. And the analysis of the tumor, as you can see, ER positive, PR positive, HER2 negative, it's grade 2. So in the old days, I would say as far as 7 years ago, 100 women, most of the time, if she sees oncologist, she will be offered chemotherapy. So now with the new technology, we ordered the Oncotype DX on this patient, and her score is 4. If you remember, we said 18 and below is low risk. So this patient, her benefit of chemotherapy is extremely negligible because her risk of cancer coming back distantly or outside the breast in the coming 10 years is 5%. So that's very low risk, to the point that offering this patient chemotherapy is actually not beneficial, but can cause side effects. So this patient, we sit with the patient and give her this information. And we have a lot of data to support that there is no need for chemotherapy. And we save this patient a lot of side effects. In comparison to this lady who's postmenopausal, pretty close to the size of the tumor, 1.3. So basically it's a small tumor, strongly estrogen positive, PR negative, HER2 negative. The grade a little bit higher, kind of concerning. So in the old days, sitting with this patient, probably it's going to be hard to offer chemotherapy, but sometimes we will offer chemotherapy. So a lot of oncologists at that time would say, this is postmenopausal, low grade, small tumor, I will not offer you chemotherapy. We did the test on her, the Oncotype DX, and look at her score. Her score came at 34. That translates into a 10 years period from now, her chance of coming back, the cancer coming back in the bones and the lungs in other areas outside the breast and the lymph nodes is 23%. Keep in mind, most of those women, they received hormone therapy because it is the standard of care that if you are estrogen positive, you need to have at least 5 years of hormone therapy. Maybe some patients might need even 10 years. So this is a patient who has significant risk of recurrence. And this is the patient I will offer her chemotherapy, and her benefit is significant from chemotherapy. So in general, Oncotype DX, I'm sure you heard about it, some of breast cancer survival. It is approved for some time till recently for patients who are what we call node negative, estrogen positive. But in the last couple of years, there is more data showing that if you have 1 to 3 lymph nodes, and you are postmenopausal and your score is below a certain number, I don't want to give you the confusing data, but it is in general below 16 or below 18, that there is not much benefit of chemotherapy. So even though node positive disease in the old days, every patient with node positive disease, whether premenopausal or postmenopausal, they were offered chemotherapy. Now, 1 to 3 nodes, and they're postmenopausal and their score is low, we will not give them chemotherapy. There is another test called Bamaprint. It has been getting more popular in the last 3-4 years, and it's mainly for patients with node positive disease. And this actually very close to the Oncotype DX. It gives you actually what we call dichotomous, risk, high or low risk. The advantage of Oncotype is like a linear. It gives you the number here. It only tells you if you have high risk or low risk, but it's mainly designed for patients who had node positive disease. And we have been using it in the last few years. So moving forward to targeted therapy, this is like an important topic for a lot of cancer, and breast cancer is one of them. So instead of chemotherapy, we're trying to understand certain mechanism of cancers. If you look at the cancer cell, we don't understand it, honestly. Every day there is a new pathway. We call them pathways. Cancer cells, the way they divide, the way they communicate with each other, and the way they spread from the primary tumor to the bones is through certain antennas on the surface of the cancer cells. And for the antenna to transmit the signal to the nucleus, this is the nucleus here. It has all the machinery for DNA replication and transcription and translation into proteins. There are millions of pathways, and we have maybe right now maybe a few of them. And scientists each day there are new pathways that are designing new drugs for them. And I think we're familiar with the HER2. The HER2 is, as I mentioned before, it's expressed in 20% of the time. We have Herceptin. I don't want to, this is maybe another topic we can talk about it. We have at least now 7 to 8 drugs approved for patients who are HER2 positive in different stages. Immunotherapy is important. It's mainly around now for triple negative breast cancer. It has been approved 2 years ago for stage 4, and just 2 months ago approved for patient who has what we call locally advanced before going to surgery, what we call neoadjuvant chemotherapy. This is a drug Keytruda, by the way, pembrolizumab. It is now approved in 34 indications in cancer, not breast cancer, in a lot of cancers. So it's stage 1. So it's amazing. It's kind of becoming a specialty by itself to be specialized in immunotherapy alone. Let's move to chemotherapy because it's still used frequently in patients with breast cancer. It's still a treatment that we try to avoid, but unfortunately we have to use frequently. And there are different classes of chemotherapies. They work by different mechanism, what we call alkylating agents. The famous one is cyclophosphamide. We use in breast cancer. We use also platinum called carboplatin and cisplatin in certain patients. Anti-metabolites. This is another class of chemotherapy agents. Methotrexate in a regimen called CMF. Also, there's taxanes. These are big class of drugs. We use them in many cancers: lung cancer, colon cancers, breast cancer, ovarian cancer. Particularly paclitaxel or Taxol and docetaxel, Taxotere are heavily used in breast cancer. The anthracyclines, these, especially what we call the red devil, the doxorubicin, this is still heavily used drug in breast cancer. So this is like summary of some of the regimens. I'm sure breast cancer survival, they heard about these abbreviation. We love abbreviation, in medicine because we use a lot of big names. So this is one of the most commonly used regimen called dose-dense AC followed by Taxol. It's adriamycin, Cytoxan, Taxol. Dose-dense, it means most of chemotherapy in the past, we used to do it every 3 weeks. Dose-dense, we do it every 2 weeks. And usually, we do it for 4 cycles, followed by Taxol for 12 cycles because Taxol is given every week. And this is a standard regimen that we give adjuvantly and sometimes neoadjuvantly to patients with breast cancer for stage 2 or 3. Taxotere and Cytoxan is another very famous regimen. When we like to avoid anthracyclines, the adriamycin, which has the potential side effects, we'll talk about it, can cause cardiotoxicity and heart damage. If you want to avoid that, certain selected patients, they benefit from this regimen, and it is as effective as what we call dose-dense AC followed by Taxol. CMF, an old regimen, has been in the market for 15, 20 years or more, actually. Some of those drugs actually come in orally. It can be easier to give into certain patients. We are using it less frequently than the other 2 regimens I mentioned too. TAC, as I would call it, heavy duty, is 3 drugs, very toxic, but can be helpful in certain selected patients. Single agents, we use a lot of single agents, particularly in patients who have stage 4 disease. In patients who has like surgery, neoadjuvant or adjuvant chemotherapy, we are treating for what we call curative intent, we use combination therapy. But unfortunately, if somebody has metastatic disease, most of the time we use single compounds like cisplatin, carboplatin, vinorelbine or navalbine, eribulin, relatively new drug, gemcitabine, and also this is a drug we use it less frequently than before, called exabeblone. Oral agents, we have this agent called capecitabine. It's a chemotherapy, by the way, even though it's given orally. It's called Xeloda. We use it also in a lot of cancers like colon cancer and breast cancer. And there is a new technology called antigen or antibody drug conjugate. What they do in this technology, they design certain antibodies that targets receptor on the cell membrane, and they attach that antibody with what we call chemotherapy. But that chemotherapy and antibody goes particularly to certain cells, mainly cancer cells that have that marker. So basically an antibody, a missile with a payload, and this is a drug called sacituzumab. It is approved for patients with metastatic stage 4 breast cancer. It has to be triple negative, and it's very effective therapy. And this technology is evolving on a rapid pace in the last 5 years. And I'm sure you guys are familiar with anti-HER2 therapy, which includes Herceptin, pertuzumab, and as I mentioned, there are at least 5, 6, 7 drugs approved for HER2 breast cancer in different settings, whether adjuvant, neoadjuvant, stage 4. Side effects of chemotherapy, sorry for this busy slide, but on the left side here, pretty much every system in our body can be affected by chemotherapy. And there are certain chemotherapy toxicities that kind of unique to certain chemotherapy classes. For example, bleomycin, we don't use it a lot in breast cancer, but we use it in other cancer. It can cause lung toxicity. Doxorubicin and the class called anthracyclines. This is what we call the red devil that patients call. This is very effective chemo. It's been in the market for a long time. It is known to increase risk of cardiac toxicity. Cisplatin is known to cause issues with kidneys. Cyclophosphamide, we use it heavily in breast cancer, but the doses that we use, it can cause something called hemorrhagic cystitis. We always look at the urine, make sure that the patient doesn't have blood in the urine, etc. And vinca alkaloids, including vinblastine, vincristine, we use it less in breast cancer, but they can cause neuropathy. And also taxanes, by the way, another class of drugs that are known to cause neuropathy. So chemotherapy side effects, the side effects can happen sometimes immediately, sometimes can come early and late. So if you look at the immediate side effects that could happen in the infusion chair, anaphylactic shock, thanks God we don't see that because we pre-medicate patients these days with certain drugs that make this risk is very low. Cardiac arrhythmias, extremely low with a lot of chemotherapy. Obviously extravasation, something we watch carefully, but now we use a lot of what we call ports or major, or central lines. So the risk of extravasation when you use a port is very small, and it's particular to certain patients for certain drugs like anthracyclines, cyclophosphamide. And there is a protocols for each infusion center how to deal with extravasation. Early side effects, nausea, vomiting, usually in the first 24 hours. Fever, hypersensitivity reaction. It can manifest after the patient leaves the infusion room. They might have shortness of breath, they might have a drug rash, etc., as well as I mentioned, cystitis from certain chemotherapy. Intermediate duration within days, like maybe up to 5-7 days. Marrow suppression is important. We're going to talk about that. Marrow including white count, platelets, and red cell count. Late nausea can happen in patients with chemotherapy up to even 5 days or later. Stomatitis and diarrhea. Stomatitis, basically soreness of the mouth, cause mouth sores, dysphagia, difficulty in eating, and diarrhea, and we'll talk about that in more details, can happen lately. Renal toxicities, most of the time it can happen later with cisplatin and other chemotherapy. Neuropathy, usually late, after a few days, maybe even later, or maybe weeks, with taxanes and like oxaliplatin. There are very, very late chemotherapy side effects that could happen in months, particular damage to the heart, liver, lungs, patients who develop like what we call heart failure. When we use a drug called anthracyclines or adriamycin, there is a limit of how much you can give chemotherapy. Once you reach that limit, basically like 400 milligrams per meter square, the risk of cardiac damage goes significantly. So we watch very carefully how much chemotherapy the patient receives. Liver toxicity, patient can develop sometimes hepatitis, inflammation, liver cirrhosis, etc. And obviously for young patients, we are always concerned about the reproductive system. There is good risk of patient, become infertile from chemotherapy. And now we have new ways of decreasing that risk by maybe preserving the ovum or sometimes we give certain drugs to protect the ovary. There's injections that we give to patients to kind of shield the ovary from the effect of chemotherapy. So management, I think Very important patient education. In our practice, we always make sure that patient meets with the doctor, obviously, and then we have 4 nurse practitioners that patients sit with the nurse practitioner for an hour, whether like face-to-face or, virtually, going through the details of the chemotherapy side effects. They are getting like brochure about that. So patient education to me is extremely important. Set the expectation, what you are expecting, because I mean, if you tell the patient not much and he goes home and start having side effects, they will be alarmed. So education to me is extremely important. And we always like to prevent, prevention is much better than a cure, particularly to certain side effects, particularly, like nausea. We like to review labs, and we have to make sure that the patient is ready to start chemotherapy. And we have to make sure that kidney function, blood count is adequate, because I mean, if the patient has low white count to start and you give them chemotherapy, they're going to have definitely side effects down the road. What is the hydration status? Dehydration is extremely difficult, on patients. So we always, hydrate the patient. We bring them frequently, particularly certain drugs like cisplatin, to kind of preserve the kidney. Fever, patients are educated that, you should have a thermometer at home. You have a temperature more than 100.4. Don't take Tylenol, that's it, and forget about it. Call us. We have to, when you have fever, we'll talk about it in more details, as well as also baseline testing for the heart, especially if you're going to get anthracyclines or Herceptin. Nausea, vomiting, I mean, it's still a concern on a lot of patients. And this side effect, it's regimen dependent. And there are certain chemotherapy like cyclophosphamide, cisplatin, anthracycline. They are called highly emetogenic drugs. And each class of drugs, according to the risk of nausea, we design the pre-chemotherapy nausea medicine. And we'll talk about that. Like if you look at this combination, we give now 3 to 4 drugs to give these patients. For example, cisplatin in the mid 80s or in the 90s, we didn't have good drugs at that time. They used to admit patients to the hospital just to take care of the side effects of chemotherapy. With this combination, Zofran or Aloxi or dexamethasone, and there is a new class of antiemetic drugs called neurokinase, apripitant is one of them. With this combination, the risk of nausea in these patients can be very, very minimal. And there is a new drug that we've been using lately more, and it's actually antipsychotic. We use it for patients with anxiety, schizophrenia. And you have to educate the patient when you give this drug. Oh my gosh, you give it to patients with like bipolar disorder, but it's been very helpful in selected patients who had what we call delayed nausea. And late nausea, it can happen up to 5 days. So patient can have nothing when the patient comes for chemotherapy, day 1 or day 2, but day 3 and 4, they start having nausea. And there are a combination of drugs that we give to patients that can decrease that risk. And also, when the patient goes home, we give them what we call rescue medication. They get like routinely, the nurse practitioner who educate the patients about chemotherapy, they get at least a couple of drugs like Zofran and also other drug called Compazine. And sometimes anxiety can be a kind of a manifestation of nausea. And we find that giving anti-anxiety medication like lorazepam or Ativan can be very helpful in these patients. Very important for the patient to be engaged with a physician and nurse practitioner regarding the side effects. Diarrhea is another side effect that we see selectively with certain chemotherapy regimen, particularly like TC or AC, and also the Xeloda, the oral that we use, and different stages of diarrhea, what we call grade 1 through grade 5. And we like the patient to notify us immediately when they have even one grade 1. So grade 1, if you have like less than 4 bowel movements, in general, is an outpatient management, more education, more drinking water, avoiding certain foods and alcohol. And they can get along with or get by with just over-the-counter Imodium. Sometimes we give them prescribed medication that can be a little bit stronger than loperamide, but most of the time, this thing's getting better within a few days and patient will do fine. If the patient has grade 3 or 4 diarrhea, they can be dehydrated. So in these situations, frequently we bring them to the infusion center. because we like to avoid hospitalization, especially in the last few months because of COVID. Now, patients go to the emergency room, I assure you, they can spend 12 to 24 hours in the emergency room because we don't have beds. So we are very aggressive in seeing patients, outpatient in the clinic. We bring them sometimes daily hydration. We give them IV medicine here in the infusion. And in the vast majority of the cases, thanks God, we can avoid hospitalization. Febrile neutropenia is a very serious side effect from a lot of chemotherapy. And by definition, febrile neutropenia means the patient has low white count and has a fever. And the fever has to be above certain number. Classically, we used to say 101, but we tell our patient that 100.4 and above, and you should have a thermometer, you should call us. And there are degrees of neutropenia, depending on the white count, what we call absolute neutrophil count, or what we call the infection fighting cells. Not the total white count, it's the neutrophil. And if the neutrophil, above certain level, like 1500, that's called normal, and usually they do fine. But once the neutrophil count go below 1000, which we call moderate, or severe below 500, the risk of infection goes significantly. And also the duration of neutropenia. Because if neutropenia lasts for a day or two, that's not very risky, because now with a lot of regimen, by the way, dose dense AC and TC, we use what we call GCSF support, or what we call a growth factor that mitigate that risk. So even though with those regimens, we see still small percentage of the patient they present with febrile neutropenia. So if the patient has febrile neutropenia and their neutrophil count is really low, and their fever is above certain limit, if they're above 101 and they're not feeling well, they have to see the doctor because they might need IV antibiotics. But if they are feeling really sick, or if they have a lot of comorbidities, patients have diabetes, kidney disease, they have multiple regimens of chemotherapy in the past where we know that their bone marrow reserve is not great, these patients, we know that they're going to be neutropenic for a long time. So the better they come to see the doctor or go even to the emergency room if they are not stable. How we manage these patients? In general, we divide them into low risk. I don't want to bore you with the details about that. But if they have like borderline neutrophil count and they have low-grade fever and their blood pressure is fine, they come to the clinic, we assess them. Sometimes we do chest X-ray, we do blood cultures. We give them a course, one dose of IV antibiotics in the clinic, and we give them oral antibiotics, and we see them in the coming few days how they're doing. But let's say if they have very high fever and their neutrophil count is very low and they have other issues, we admit to the hospital. We do cultures from the peripheral blood, from the port, because sometimes the port is the source of the infection, and we give them broad spectrum antibiotics. We see them in the hospital. Sometimes we consult with the infectious disease specialist. We will wait for them, for the fever to go down, for the neutrophil count to recover. And once they are stable and the neutrophil count above certain limit, like 1500, and they have no fever for 48 hours, we discharge them on oral antibiotics. And obviously, when they sustain these side effects, we look at the subsequent cycles. We dose reduce, we delay the chemotherapy by certain days till their count recovers. Neuropathy is also a very serious side effects, because unfortunately, patient can live with this neuropathy for a long time. And it has a lot of classification. Most of the time, it is sensory neuropathy. Patient present with kind of numbness, tingling, pins and needles. Patients sometimes say, "Doc, I cannot walk. And when I cannot even put my button my shirt." So you have to look at the degree of neuropathy and how severe the neuropathy. And obviously, neuropathy is what we call dose cumulative. Certain chemotherapy like Taxol, once you reach certain number of cycles, we stop. We don't continue with chemotherapy, and we sometimes reduce the dose. So this is very important to keep in mind. And neuropathy in general, it is symmetrical and starts in the fingers and the toes. And again, it depends on the regimen. Most of the drugs that we use that can cause neuropathy, taxanes, Taxol, anthracyclines, they are not known to cause neuropathy. Vincristine, vincristine, also these are drugs that can cause a neuropathy. And oxaliplatin is a well-known. We didn't use it in breast cancer a lot, but it's mainly used for colon cancer and GI cancers. So how to manage neuropathy? We like to decrease that risk, but there are non-pharmacological and pharmacological therapies. We start with simple things. We try to avoid drugs as much as possible. We can reduce the dose. We can also avoid certain temperature extremes. This is very important. Patient tell them avoid extreme temperatures. Activity, yoga, and stretching and exercise, even walking, can decrease the neuropathy significantly. Massages also can be very helpful. Acupuncture as also. There are different drugs that we use in medically to decrease the neuropathy or the symptoms of it when it becomes like symptomatic to patients. Gabapentin or Lyrica and other class of drugs we call anticonvulsants that are very helpful, and we can use different doses. We always start with a small dose because this class of drugs can make the patient sleep a little bit, and sometimes patients like it. They take a drug, a dose or two before they go to bed, and they can help them a lot. Tricycling antidepressant, very common drugs that we use for also neuropathy. When sometimes there is pain, unfortunately, we have to use patient medication like narcotics or tramadol. Hair loss, I think it is very important, very dear to patients with breast cancer. There is a survey that they looked at many patients and they looked at what are the most distressing side effects to women. And actually, if you look at hair, almost like 80%, it was ranked as #1 side effects to patients from chemotherapy. And again, I don't want to give you a lot of confusing here, a lot of details here, but in general, there are certain drugs that can cause significant alopecia, like anthracyclines, cytoxan, taxanes, very, very common. And we know these drugs are heavily used in breast cancer. So the risk of what we call alopecia or hair loss in these patients is pretty substantial. So we would like to decrease that. So honestly, for a long time, we didn't have much to offer to decrease the risk of alopecia in certain patients with breast cancer getting chemotherapy. There is a concept called scalp cooling, which is basically if you reduce the blood flow, the theory behind it, if you decrease the blood flow during the infusion chemotherapy, which is very important, it can decrease exposure of the hair follicles to chemotherapy. And that can help reduce the risk of alopecia and can kind of allow the cells in the hair follicles to survive. And this is actually evolving. We're going to talk about it, and we have it available here in our cancer center. It is used way more overseas than in the United States because in the United States, it has to be covered by insurance. And unfortunately, most of the insurance companies, with some exceptions, they don't cover it. There is some patients that can afford to get this treatment and get what we call cooling, and can decrease the risk significantly. And now we have better studies that showed efficacy in more what we call randomized way. So they have big studies right now that compared it to the typical way of doing that, which is like what we call hair prosthesis, and we found that it can be very helpful. And this is the way it works. It's a device. It's basically the patient sit in the infusion chair. There's what we call fitting method, and always the cap is going to be fitted to the patient. There is a pre-infusion cooling time, about 30 minutes, that the patient cool the scalp, and then they get the chemotherapy. And during the infusion, they get also the cooling, and there is also post-infusion cooling. Our nurses are well trained regarding this, and the patient get a lot of education about that. And it's very helpful. And if you look at this patient who received chemotherapy, it's TC, and we know the risk of alopecia in these patients after a cycle or two is substantial. In the left here, the control arm, you see cycle 1, and also by cycle 3, the patient lost all the hair. Versus somebody who used the scalp cooled technique, they preserve the hair in most of the cases. So very important. I want to go back a little bit before. I think there's another picture. I thought there's another picture about the cool capping. So anyway, cool capping technology is evolving. There are different machines available in the market. I think the two most common that kind of approved to some degree by, I will say, by the authorities, but is not approved by the insurance yet, or is not covered, it's called DigniCap. It is available in our center. We have 2 infusion places, and we have it available in both areas. I want to talk about community oncology briefly. As you know, patients would love to have their care close to their home and close to where they live. And we have a lot of cancer centers across the country. We have great, what we call cancer centers, NCI designated. They do a great job in coming in new treatments, clinical trials. But I think still patients, they love to have like what we call private setting where they get their care. And also very important to keep in mind, I think cost is very important. And I think, how much we spend, money in healthcare and keeps going up and up. If you look at the cost of chemotherapy, I think this is one cycle of chemotherapy cost in a private setting versus what we call hospital-based practice. There is substantial difference in cost. And a lot of times it's covered by insurance, but also frequently the patient, unfortunately, can be responsible for part of that cost. So treating patients in a private setting versus what we call hospital setting can save the patient significant amount of money, not the patient, also the insurance companies as well. So this is one of our patients here. We have well-trained nurses, through the help of what we call COA, which is Community Oncology Coalition. This is very well-known organization across the country, help educate patients and the community that, like to keep, cancer treatment in the hands of the community doctors. This is the picture of, a couple of my nurse practitioners and the nurses here. And I think somebody took the picture with Leslie and Sherry here in the pink house. And this is, the picture of, me in the cancer center. And this is another picture just showing you what we offer here. This is the DigniCab that I mentioned, briefly, that we have it available in our 2 infusion centers. That's available in the Uptown Eastover campus here, and also in Pineville. And this is the infusion center. It is not very fancy, but it's very family oriented. Patient treated in a very family atmosphere here. Nurses and MAs and everybody knows the patient. Patient comes and see the same nurse every time they come for chemotherapy. And this practice has been in the community here for the last 21 years. We're looking forward to continue serving our community, particularly breast cancer patients. And I appreciate your listening, and I'm going to give you some time for questions. Thank you.
Thank you, Dr. Shehadeh. That was wonderful.
Thank you. I'm sorry it took maybe a longer time. My gosh, it's 6:30. Oh my gosh.
That's okay. Your slides were beautiful and so easy to understand. We appreciate that very much.
You have stopped me and said me just enough information.
Okay, ladies. Who has questions?
Any question? Doesn't have to be about chemotherapy. Anything related to breast cancer. Somebody's trying to say something, maybe muted.
Everybody's
I'll
quiet.
ask a question. This is Julie.
Hi, Julie.
I'm just wondering about the community oncologist. Like, how would you go about? Would you have to go to like a certain doctor there, or how would you?
We are community oncologists, but we also part of certain programs here, like we attend the tumor boards, in the hospital. We work with a lot of doctors in the community, whether they are employed by the hospital or in the private, because cancer care, it's not only medical oncologists. We are medical oncologists who, I would say, maybe the quarterback of the cancer care, but we work with radiation oncologists, with surgical oncologists. We work with other what we call supporting staff, regarding, a lot of issues for cancer. But community oncology, unfortunately, it is, I would say if you look at in Charlotte, we have like few practices because hospitals bought a lot of practices because, for whatever reasons. And I think they do a great job. I work for a hospital and I think we took good care of the patients. But my experience, patients feel that they are treated in a private setting, they feel like the attention more different than when you go to the cancer center, where sometimes, to be honest with you, when you call for a question about your side effects, each time you call, guess what? You're going to get maybe an answering service, or you're going to get what we call answering service for that program that doesn't know anything about the patient. Maybe they know just your chart by looking at the medical record, but they don't know you. That's why the importance of seeing community oncologists and private doctors, where everybody knows you, from the nurse, from the doctor, from the front desk.
Yeah, it seems a lot more personable, and it just seems like the experience would be so much better.
And patients deserve that, because it's cancer care. It is very, private. It's very special, and it takes a lot of time and discussion and involving the family. It is not only a patient cause. It involves a whole family.
Right. Thank you.
You're welcome, Julie.
This is Darlene. I have a question in regards to the cap, I guess the DECA cap, the process. Yeah. As you know, as minorities, our hair is very different type of course with the different diversity. So do you know the statistics of anyone that has used it in minorities, if how the hair has grown back? I've heard about it, but I've asked, but no one has actually given me any statistics on in African American women, how the hair has grown back by using that feature.
That's a good question. Unfortunately, the research in this field is still premature. We just we have big phase 3 trial that was done in this country to show the benefit. Let alone that looking at the minorities that are African American. We know African American, they are underrepresented in a lot of clinical research, and including breast cancer. But personally, I have currently a patient who's African American. She's receiving the DigniCap and she's doing well. I don't see a huge difference, to be honest with you, in efficacy in terms of the hair loss. I think it should work as good in African American as Caucasians, but I cannot support that with data because we don't have data.
Okay.
Thank you.
Thank you.
So everybody's doing good?
I have a question.
Yes.
This is Pam. Is the DigniCap process and all of that offered only at Oncology Specialists of Charlotte in your office, where else in Charlotte?
I honestly, when I know that Novant don't offer it because I was with Novant. I'm not sure about Atrium, to be honest with you. There is another private practice in the north. I don't know, Sherry, if you have that information, whether the other group.
If you go to their website, the DigniCap website, I could go to here on my.
I actually know Atrium does because I'm actually in my stage of taking chemo now. And it was presented to me by my oncologist there. That they just started it there at the Levine Cancer Center.
I had heard they were getting it.
They have it.
That they were.
Good.
Let me tell you
That's
what,
good. That's why I wondered.
Yeah, there is a question that I forgot to tell you about that. There is a concern in the past that if you do what we call scalp cooling, that you might kind of protect certain cancer cells that might be hiding there. And that's one of the concerns, on the behalf of some investigators, but if you look at the studies, this is, never been proven. So, I mean, that's one of the concerns. Like, are we kind of freezing the cancer cells in the scalp, and once we're done with the treatment, they might come back later on?
Mhm.
But this is being disproven by multiple like case series, etc. So this is not a big concern.
And I know if you call them, they're very helpful with
Yes.
asking questions, because I've been in talk with them. So Pam, I know if you reach out, they're very helpful, giving you more information, and also of the surrounding areas that here in this local area that provides it.
I
Right.
hope at some point
Right.
we'll be approved by insurance. We need to
Yeah.
market for
Mhm.
approve it.
Yeah.
Well, I'm glad to hear that, because we've had a good friend of mine has used it, and very successfully. And but at the time when she did, which has been almost a year now, maybe 7, 8 months, she went to Duke. But since then, it has come to Charlotte. So how long is Oncology, have you all been using it?
We were actually the first in Charlotte area.
Okay.
And then in the eastern part of the state in Raleigh, another clinic had it. So we started in 2017.
Okay.
Awesome.
Wow, that's
But
great.
it evolved with time. It's becoming more easy to use
Right.
than before.
Oh,
And
it's we're actually on our second edition. It's the first edition. They just, with all the research and
Mhm.
troubleshooting for getting the cap to be comfortable and fit so that you don't lose the coldness, or that's what you want to aspire, is to pretty much just contain that cold. But we're on the second generation of the DigniCap unit called DigniCap Delta. Some other things that have changed over the years with it is I've heard some insurances, I say some, maybe one out there too, and they're talking about it with others, not maybe approved yet, but like approaching Blue Cross Blue Shield. And they're spot on to say, hey, you'll cover a $1,300 wig. That's an insurance coverage program for alopecia due to chemotherapy. So if you're going to cover a $1,300 wig, could you just give me $1,300 towards the DigniCap? And then I won't be needing a wig, or I will have forfeited that chance for a wig at $1,300.
Right. So do you all do that?
It's up to the insurance.
Okay. But some are doing it.
Oh, uh-oh.
we lost.
I think we just lost her.
I think we lost her. I think she jumped off.
Interestingly, I'm an old chemo nurse and gave chemo back in the late 1970s and early 1980s up until 1987. And we had a version of the cold cap back then, but it was probably a dinosaur version. But I remember, because adriamycin has been around a long time, and the vinca alkaloids and all the things that can cause hair loss. And but we did have it back then, and patients were trying to use it, and we had some success, but probably not as much as we have now.
Even like if you cool the hands and certain chemotherapy, you can decrease the risk of neuropathy too. So it's an old concept, but the DigniCap, they did it in a nice way, how to fit the cap and how the cooling mechanism also.
Interesting.
Yeah.
So do physical therapists use cooling and cold for neuropathy and stuff in their procedures and treatments?
Yeah, you use cooling during the chemo, but you don't want to use it when somebody has established neuropathy, because it can be
Right.
irritating.
Right.
Yeah, so during the infusion, like
Right.
if you give Taxol and you keep the hands in a cold, that can
Yeah,
decrease the risk of
right.
neuropathy, but not
Yes.
later.
Right.
I mean, this neuropathy is an important topic that we still struggle for a lot of patients, unfortunately.
Do you find that any of the creams work on neuropathy? I know there's some on the market.
Yeah, there is one that it's called capsaicin. Sometimes might help, but it's actually from pepper, by the way. So but it can be helpful. Here's Sherry. You're back, Sherry.
My battery died. And then you have to wait for it to just kind of slightly get a little juice. It's plugged in now. I'm so sorry. And then I had to get back into the passcode. I was saying the insurances, I mean, it just, you would have to check with the insurance yourself on it. However, there are some organizations who will help some women with the nonprofits. There's one called Hope for Hair. They might give out grants or offer some type of support. I do know that this is all, I mean, I don't know how the Levine Cancer does their DigniCap. I mean, it's all different, but ours is you set it up with payment to them. So, and they'll do like a payment plan. It's not like you have to pay it all up front. And I understand too, it's really neat. Like you get to a certain point, like if you keep having per treatment, you pay, but you can only pay up to, and don't quote me on this, I'm trying to remember all the details and it could have changed. I think it was $1,800 total, like up to, if you keep having treatment, and then they're your lifetime. You never have to pay again. You could just continue. If you have a relapse, you just come back and you can continue to use it for life.
That's nice.
Yeah, it's good to know.
Anybody else have any questions? I love it when we have a captive doctor and, he's right here waiting just for our questions. So I don't want you to miss this opportunity.
Any question about any cancer or blood disorders? Everybody?
I have a question.
Yes.
What would be the reason for 5 years of hormonal therapy as opposed to 10 years?
Oh, that's, the reason, if you look at ER positive breast cancer, if you look at the patients versus triple negative, half of the recurrences, actually, if the cancer is going to come back, let's say a patient has 20% chance of the cancer coming back and is estrogen positive, half of that risk falls between year 5 and 15. Even 20 years. The cancer, I have seen good number of patients that cancer, God forbid, comes 15 to 20 years later. And that's the rationale behind giving longer duration of hormone therapy. Versus what we call it triple negative, which is more aggressive. But once you reach 3 and 5 years, you can tell the patient with more comfortable situation that the cancer recurrence rate is very, very small. For estrogen positive, even though less aggressive cancer, because it grows less fast, slower. And that's why you give hormone therapy.
Okay. Yeah, because I have 10 years, so I was just curious about that, but that would make sense.
Yeah, we're still debating that. We're going to debate that for another 10, 15 years. 5, 7, 10, we don't know. So we ask.
They did a lot of research studies on that very question. And so the decision now to give the hormone treatment longer is based on the results of the research studies as well.
Okay.
And now there actually, as I mentioned, there are genomic testing. Actually, it's called breast cancer score. There is a gene testing that can show whether you benefit or you need hormone therapy for a long time or not.
Okay.
Things are improving.